Okay, I think we'll get going. Let's see. Can you all hear me pretty well? I did. But I can never hear that it's... Okay. So thanks for being here. I'm Allie Kemp. I introduced myself last time, but I know some of you are new. How many people were not here the first session? Okay, lots of you. Hi, how are you? Okay, well, the first time we went over what the core program was about, what outcomes research is, and all the many labels that are often included under outcomes research. We sort of walked through an example of sort of the whole curriculum in a way, going from the importance of asking a good study question to methods to analysis to sort of give you an overview of all that. And then we talked a little bit about training and what's required. So unfortunately, some of you may want to go back over some of those topics, and if we have some extra time today, please feel free to ask questions. But first of all, before we get going, any comments or questions about last time? Things that were unclear or thoughts you had? Yeah.
I think there were a lot of those the terms and the kind of headings, but I would find it helpful to know of a few papers or topics. Could you tell me a couple of examples of things that would have been considered outcomes research in the literature?
Sure.
Maybe ones that have been done here. That would be helpful.
Sure. Just sort of the kinds of things, or I mean, everything I do is outcomes research, for example. So you want me to just tell you about a few projects?
Yeah.
So in the comparative effectiveness area, pragmatic trials.
Okay.
We are currently conducting a pragmatic trial in... thank you so much. Okay, great. Thanks a lot. In 14 counties in Colorado, where half of the counties are randomized to an effort to train and get practices to do reminder recall at the practice level for immunizations.
Okay.
The other counties, we're involved with the state health department, and they are doing a centralized reminder recall effort aimed at the same thing, trying to get kids up to date before preschool. We're comparing the outcomes, we're comparing costs.
Okay.
That's sort of at a community or almost at a state level, okay? We've done a lot of trials in private practices where we randomize at the level of patients to see if things like different types of interventions at the practice level are more effective than others, to directly compare them. So those are comparative effectiveness types of trials. Outcome studies, often they can be simply descriptive, where you use a data set that's very rich enough to describe the outcomes of different procedures, that kind of thing, or you may even compare the outcomes of different procedures. We're actually going to talk about an example of that in just a minute. Let me see, what else did we talk about? Health services research would be all of those things. Might be focusing at the level of the patient, or at the level of the practice, or at the level of the whole system. Okay?
Okay.
Are those helpful?
Yeah, that's helpful.
Okay.
And then my other question was that when I had heard about comparative effectiveness research at another conference, for anti-seizure drugs, it was one of the big topics was that type of research is done more often in Europe, and some data has come out from that, but that it's kind of frowned upon by it, not frowned upon, but not considered to be accurate or effective from the FDA standpoint, because it is not a randomized placebo-controlled trial. However, it has, obviously, as we're discussing, many implications that are valid in and of themselves. So how does one go about kind of getting funding and dealing with the fact that this is still kind of considered, second-class research, even though it reflects many of the issues that practitioners face on a daily basis?
Well, there's a whole lot of issues in what you said. First of all, the kind of research you were probably, that they were talking about was called observational comparative effectiveness research. OSER is the time. That's the way comparative research actually developed first. And that research, that focus, that type of research involves looking at huge databases and then trying to control for differences between populations using some pretty sophisticated analytic methods. People do have a lot of problems with that. I have a lot of problems with it. I think it's very useful in some ways, but I think it's not very definitive in some ways. So that's a particular brand of comparative effectiveness research. I think the larger label of comparative effectiveness research, there's a lot of different types of research, like the example I just gave you, where there's really no other way to see what works in a real population. And you can actually do very high-level science if you think carefully through the issues. There are people that have been trained in the basic sciences who will never give credit to this type of research. But you know, there's a lot of funding agencies that are recognizing that basically we need to apply the same level of rigor and try to do real science in real life clinical situations, because continuing to pretend we can do it in a laboratory and then that will relate to the real world really is not working, because as we discussed last time, the vast majority of research never gets translated. So in terms of funding agencies, we can go into that at some point. I think probably we should do it later on in the course, but I would be really glad to talk to you about where the funding is coming from at this point. Okay? All right, so we're going to focus today on writing a good research question. And I've been training faculty and fellows for many years in this area, and invariably they think this is like so basic. Why are we talking about this? We do not need to deal with this. And then, for example, in our fellowship, we end up spending most of the year refining people's research question, because the bottom line is it is the structure on which you build the house. Everything else follows from the research question. So even though when you start writing research questions, you may feel like, this is like so obvious, you will discover how wrong you can go if you do not spend a lot of time up front with this. So we thought we'd start with an example of that might illustrate the importance of carefully articulating the study question. So here's an example. Dr. Brown, who is a pediatric surgeon, has access to a database of nationally representative pediatric hospitalizations. And many of you probably also have access to either KID or FIS, which is the pediatric hospitalization databases, or many of you, not most of you, have access to EPIC now. And so this is a common thing. People are realizing they've got access to data. Great. They want to use it. So she is interested in seeing if there's a difference between two types of procedures for a surgical outcome, either doing it laparoscopically or open. So she consults with us, and she provides us with the following information. Her aim is to compare outcomes of children receiving the surgery by these two methods. And her hypothesis is that the laparoscopic procedures will be associated with better outcomes. And she has defined some outcomes, and she thinks she's most interested in length of stay, hospitalization stay, and the time from the procedure to first feeding. So she's defined some outcomes. Okay. So let's discuss her plan here. What is her study question? Can any of you... Oh, and we have to use the microphone, I'm sorry to say. Is this on? Okay. Can any of you try to articulate what her study question is? Let's go back. Give it a stab. That's what this session is about. It's supposed to be interactive.
Well, if it wasn't the microphone, so will babies who undergo laparoscopic surgery have a better outcome than babies with open surgery as measured by length of stay and feeding?
Okay, great. So she, just to follow up a little bit, you said babies. So you might need to specify, the group a little bit more. Because, age might make a huge difference here. And you might need to specify for what procedure, because obviously this could be for many procedures. So a given procedure in a given group. So you're defining the population, you're defining laparoscopic versus open, and you're defining some outcomes. So those are the three elements, and those have been defined. Now, given that question, and let's pretend, you've correctly articulated the correct group that we can really look at and agree upon. What are the strengths and weaknesses of the proposed method here? This is a retrospective chart review looking at the outcomes. Do you see any, first of all, what are some strengths of this kind of methodology?
You'll be able to look at a larger population of children rather than waiting till each of them have had that procedure in your own given hospital or institution.
Exactly. So if it's not happening all that often, you don't have to wait for a year to accumulate the patients. That's a great point. Any other strengths you can see?
The outcomes are clearly defined and measurable. So length of stay is measurable, and time to feeding is measurable.
Hopefully, yeah. I mean, I think length of stay is very clearly measurable. Whether you can get length to feeding through the medical record, probably. Probably so. If you read through notes, you could probably get that. So
Can we talk about weaknesses now?
Excuse me?
Can we talk about weaknesses now or potential concerns?
No, any more strengths? Yeah?
Along the same lines as what I said before, is maybe in your institution, the physicians who do this surgery only want to do one method. Well, now you have a way to compare the laparoscopic to the open if they're not really doing both frequently.
Okay, so that could be a problem, you're saying?
No, well, I think it could be a strength because it gives you a way, if you're looking across
I see.
A whole database, you have more sample to look at.
I see. So
Okay.
you can compare between
It's also a
institutions.
problem, but it's...
Right. No, I see. I get your point. The other thing that you might bring up as a strength, I think, would be it's fairly cheap. I mean, all you're doing is crunching the numbers here. So that's a strength. Okay, so I can just tell you want to jump in with those weaknesses. Give me some weaknesses.
The patients who had laparoscopic surgeries might be different than the patients who had the open procedures just based on how they're presenting, and the decision-making going into which operative procedure was appropriate might be based on other factors and therefore influence their outcomes.
Right. Huge problem, right? Huge problem with this kind of design. So that's selection bias and it's could be a major confounder, as we call it, and we'll get into those kind of terms later, but it's associated both with the risk factor here and the outcome. So kids, for example, let's say that children who have more comorbidities or sicker kids are more apt to have an open procedure. They also are probably more likely to stay in the hospital for longer. So this is a very difficult source of bias, all right? And that's, in fact, can the question be answered as phrased by Carolyn? Can you answer the question that Carolyn phrased with this methodology?
It's not specific enough. I don't think it's specific enough in terms of they're not describing the condition for which the procedure is going to be performed. So,
Okay.
I mean, you might want to say for appendectomy, for example, without abscess, or being more clear about the trying to get uniformity among the patient groups, because that's not specified in the initial question.
Okay, but let's pretend it were. Let's pretend you articulated this question very well in the Could you answer this question using this kind of methodology?
I think the biggest issue with this is, having too much data is almost just as bad of a problem as having too little data. Because if you're trying to make connections with every little thing, you're just making it more complex and almost you're steering away from what you're really trying to answer. So I think it needs to be a little bit more specified. It doesn't have to be super narrow, but we need to get a little more specific when it comes to what kind of people are getting this type of surgery and what for.
Okay. Well, I think that you could probably articulate that pretty well. I agree with your point. The other point you're kind of, I think, making is about data dredging, which is that if you've got a lot of data, you can look at, if you don't have a specific question articulated, you don't have a specific hypothesis, you just sort of like checking out a lot of associations. You definitely can get very lost in the woods, and that's very bad science. Sorry.
So I think for the issue of selection bias, the other thing is that you can try to compare the two populations who underwent surgery to each other to see if there are characteristics that you think of that and how different they are among the two groups. It obviously doesn't control for variables that you don't think have an effect on surgical outcome. But if you want to compare their ages, the severity of their of their illness, their comorbidities, you can do that and see if they differ significantly from each other. And I think the question for this particular type of study would then be, if you find that there is a difference, it kind of becomes a hypothesis generating study where you can say, all right, fine, we saw in this retrospective review that there were differences. Now we can do a randomized controlled trial to decide if this actually is something that we should begin to implement as a change in practice for how we treat these kids.
So could you try to articulate what question you would be asking? Because that's a very different question, isn't it? Let's pretend you could say, I'm interested in looking at the issue of selection for these two procedures. Very different question, right?
Right.
So you could articulate a question around that would be very specific and answerable, probably. Yeah. Okay, but the point is that is not this question. Right. Okay? So that's a different question. Right. And I agree with you. I think you could answer that question. That would probably be the right way to start. And we could articulate, yeah.
We haven't defined what they really mean by better outcomes, therefore you don't have anything that's testable. I mean, how can you have a hypothesis when you haven't defined what you mean by better outcomes?
Well, they did define two major outcomes. They said, I'm sorry if you didn't, length of hospitalization and, why can't I go back? And time to feeding. So those were their two major outcomes. I mean, in all fairness, they did do that. But so we're hovering on, can we even answer that question with this study design? How would you like to answer that, Carolyn's question? What would be your preference? Yeah.
So you could try to match the patients. So assuming there are like 1,000 patients that went open, 100 went laparoscopic, you could pick out the 100 in the open that most closely matched the 100 in the laparoscopic group.
Okay. That would be a reasonable study design. So you probably, everybody's first choice in the room would say, oh, let's do a randomized controlled trial and go prospectively and determine that. Randomized controlled trials in surgery are very difficult and probably not feasible in this situation, I can tell you, given these surgeries they were talking about. So then you may have to deal with a situation where you have to do something like that, either match or control for analytically differences between the patient populations. And if you're, whether you're going to be able to do that satisfactorily just depends on how much bias there is and how much variation there is, all kinds of factors like that. Sometimes you can control very effectively between differences between populations, but if there's a very strong bias for patients who are complicated, for example, to always get the open, you're probably not going to be able to control for that or match for it. Now, there are some other ways you could be sort of clever and say, okay, well, we're just going to look at uncomplicated kids with either procedure. Or we're going to look at two sites, one site pretty much only does laps on everybody. The other site pretty much only does open on everybody. So there are some things you could do to try to get around this. But the bottom line is the study question really defines the method, and your analysis. And let's pretend you weren't using a national data set. You were actually doing a chart review. You were doing EPIC data. If you had not thought this issue through, and believe me, this happens all the time. People come to me and they've got results, and they didn't really think these issues through at all, so they don't have the data on which to control for the things they need to control for. So that's kind of a disaster, because you cannot fix that situation. I would say, 90% of the time, if you ask the wrong question, it's pretty hard to fix the study design. So I hope we've made the case, at least for the beginning, that really the study question is very key and defines your methods. Any other comments? Yeah.
Well, just a question. I understand how you were using the term match, which could be prospective or retrospective.
But I don't think of control as a word that I use for something that's retrospective. Can you explain how you use it in that context?
I'm talking about analytically, controlling analytically in a model, for example. So in a multivariate model, I don't know how many of you know about multivariate modeling, but let's say that's a model, a statistical model where you are able to simultaneously control for a lot of different things with so looking simultaneously at the effect of these different things on the outcome. So if the outcome is some binary, less than 3 days, greater than 3 days or greater for hospital outcome, then the kinds of things you would be putting in the model are probably morbidity scores, number of diagnoses, some kind of classification related to complexity, that kind of thing. So often with these retrospective studies, if we feel we can control, if we feel we can take care of analytically the differences between groups, a matched design is not necessary. A matched design is usually, although the concept is the same, that's usually more used for a prospective study where you want to match them at the beginning and then follow them. But in a retrospective study, you're usually doing that by analytic methods. But you got to be smart enough before you do the study to know what those things are and have them all planned out, because otherwise you're not going to have them. And you have to also be able to evaluate if the data set is already existing, you're not creating it, are the variables I need there? Am I going to be able to do that? So all of that work, all of that mental work has got to happen before you ever look at a data set. Okay, I'm turning this over now to Beth. Whoops.
I was going to say, but the other issue is that you're not ever going to be able to control for all of those things, right? Because there will be some things that you don't even know affect. I mean, that's the purpose of randomization. I mean, you can't do that.
That's right. But honestly, there are a lot of situations you can't do a randomized trial in.
Correct.
So you have to be that much smarter about how you're going to take care of those issues. And there are ways around it. There definitely, you can be very clever about how to figure out if there's a lot of bias in these pieces.
And I would say the theory behind that, we're going to talk a lot more about matching and so forth, but the theory behind it is if you match on enough or you control for enough confounders that clearly you're only controlling for things that are measured and observed, and we always worry about that, what we call the unobservable. So all the things that you're all thinking of that are probably not in the data set or are not in EPIC and certainly probably not in a national data set. But the theory is that if you control for enough of them, you're also hopefully capturing the unmeasurables too. But the extent to which you do that, you really never know, right? So we're going to talk a lot more about that. But any other final comments about that example before we move on? Did you have that? Oh, here, sorry. All right, so the objectives of today probably are clear to you now that we're going to talk more about research questions and research hypotheses. So we're going to do a little more background information and then turn it over to you to talk about your specific research questions. And hopefully there's a handful of you who are brave enough to give us some examples. And it's a very non-threatening environment. We're here to provide mentoring and so forth. So hopefully at least a few of you will take advantage of that. So the ultimate goal for today is for you to feel comfortable writing a clinically relevant, testable, generalizable research question related to your maybe political as well, clinical expertise. And so how do we start? Right? How do we get from many of the, often when people come for consults at CORE, they are at this area, right? They have a clinical area of interest. But our job and their job is to get down, help them to get down to this testable, relevant, generalizable research question. And so for many of you, this part might be pretty clear. If you're in an infrastructure that is thinking more about outcomes research and you have clinical specialists or experts in particular areas, it might lend itself to narrowing down your area of interest. There might be a particular initiative in your clinical program, for example. There might be a change in policy that you might be interested in the effect of. You might have gone to a national conference where, for example, we'll talk a little bit more about this, talking about the importance of measuring health-related quality of life, for example. And you might say, we should be really thinking about this more in our population of kids. So getting from here to here, for some of you might be an easier process than others. And of course, it's going to, some of the key elements to that are understanding what's already been done in the literature, right? So what have others already done in this area? What have other clinics done? What have other people measured? How have they measured it? How have they defined their outcomes? What kinds of tools have they used? And where are the gaps? And that's going to be really key. That will be key throughout this. You're going to need that for the IRB process. You're going to need it for your grant proposals or funding, or even just coming up with your research plan in general if you're not looking for outside funding for this. Understanding what's already been done and where the gaps are is going to be critical because it will help guide what your research question is and what your methods are. Identifying some relevant priorities. So these could be national priorities, like I talked about with the health-related quality of life example. It could be departmental priorities in terms of outcomes research. It could be your professional priorities. It could be funding priorities and so forth. That will influence how you progress forward with your research question. Still coming up with a strong research question is key, but then how you come down to this point might be influenced, of course, by priorities in your department. And it really will be an iterative process where there'll be many drafts, like Ali said, that she spends a year on this in the fellowship process because it takes quite a long time to go back and forth and really narrow down and come up with a very precise testable research question. All right, so just for those of you who weren't here, this is sort of the map of moving from your research question to publishing your results, and it will really be the map of this module here. So right now, we're still up in this conceptual phase, conceptualization, where we're going to be talking about research aims and problem statements and so forth. And so just to reiterate, the testable research question is going to have a defined population and potentially a subset of interest, which was already brought up a little bit in the previous example, an outcome or outcomes that are very clearly defined, and an exposure or primary comparison. Okay, so those are the three key points of a testable research question. Okay, and so we talked about this last week about the importance of the study question in this whole schema, right? There's a reason why it's first, because it sets the stage for the entire process, and I think that hopefully that's starting to be quite clear with the previous example. And so we went through this little quiz last week. So for those of you who weren't here, what's the most important part? Why is this so important? Is it important that you control for every confounder, which we talked about is clearly important? Making sure you have the most valid and reliable tool to measure your outcome. Somebody already highlighted the importance of measuring the outcome well. Defining your study question well. Making sure you publish your results in a journal with the highest impact factor. So for those of you who weren't here last week, and hopefully it's becoming clear that defining the study question is the most important step. So let's look at an actual example. So which one of these do you think is a testable research question? So we have the first one, does spinal fusion improve quality of life? Does spinal fusion improve quality of life in children with cerebral palsy? Does spinal fusion improve quality of life in non-ambulatory children with cerebral palsy? And do non-ambulatory children with cerebral palsy who undergo spinal fusion have better quality of life 1 year post-op than pre-operatively? What do you think? D, right. So D has, it's the better, I mean, there could be arguments in here about ways we could tweak this and other things you would change. It's not perfect, right? There's several things still in here that need to be explained and need tweaking. But moving from does spinal fusion improve quality of life, to me that's a clinical area of interest, and we're narrowing down now to a more precise research question, right? We're talking about non-ambulatory children with cerebral palsy, so that's our subpopulation. Our exposure is undergoing spinal fusion. Our outcome is quality of life, which again we haven't talked at all about how we measure that and so forth. The outcome, and we're talking about 1 year post-op, and then pre-operatively. So that primary comparison of pre versus post on single children. Comments or questions about that? All right. So just a few more points about why this is so important, why defining the question is so important. Because we know that research based on a poorly asked question cannot be rescued, as Ali mentioned. And because the question really sets the stage for that whole map that we talked about in terms of then coming up with your analytic approach, study design, your methods, and so forth. And somebody already highlighted that it can lead to data mining and data dredging. And for those of you who work with national data sets, and even in EPIC, if you're dealing with thousands and thousands of patient entries, when you go and run crosstabs on this, everything is going to be statistically significant because you have such huge sample sizes. Perhaps not for your specific population, but particularly when you're looking at national data sets, when you're talking about 30, 40,000 observations, anything you put in is going to be statistically significant. So if you don't have a well-defined question at the beginning, then you won't know what to make of your results, right? Because you won't know what's a true association and what's just an artifact of having a large sample size and being able to come up with a p-value that's less than 0.05 and really has no clinical meaningfulness. And so that's what this point is. You're going to likely find significant results just based on chance due to very large sample sizes. And it needs to be answerable because it will help you in that sense. The more you've defined your study question and you come up with statistically significant results that are in the expected direction, that's confirming to what you've hypothesized already because you've already delineated a very clear research question with a clear hypothesis. Whereas if you have and similarly, if you come up with negative results or things are in the unexpected direction, you already might have some hypotheses about why that's true, okay? Because you've thought about all these other factors and how they may play. And we talked a little bit last week about the conceptual model and drawing out a conceptual framework. And the clearer that conceptual framework is related to your research question, the easier it will be for you to do this part of it, to explain not only the anticipated results, but also things that went in an unexpected direction. And I will let you know this actually happened with the quality of life example. And because there was a strong conceptual model, there was a very clear explanation of why that happened. And it should matter to you, because this is going to take, it's a long process of doing this. It's a lot of work, and you have to love it, and not be answered previously, right? Okay. And so in addition to that sort of testable part of it, that's just one aspect, right, in terms of a good study question. The other litmus tests are things like the relevance of the study question and generalizability. How might you know about this part of it? Like, for example, did you think the pediatric surgical outcome, do you think that would be a relevant and generalizable question potentially?
I think it depends on where the database is from, right? So if your database is only of academic hospitals in major cities, then I think that may limit your generalizability. But if you have all pediatric hospitals, big or small, from 10 beds to 90 or 300, then I think that makes it better.
Mm-hmm, mm-hmm. So in that case, it was a national, coming from a national data set. It didn't enumerate all hospitals, all pediatric hospitals in the country, but it's a nationally representative sample. So you're suggesting that at least helps with the generalizability of the findings, assuming we came up with a testable question and went down the path of a rigorous analytic approach. Other thoughts about that, about generalizability or the relevance of the study question? How might you determine if the relevance of your study question? Yeah.
So I think you would want to know how frequently spinal fusion surgeries are being considered in patients with cerebral palsy. So if it's something that's a rare occurrence, it's not really going to have a relevance to people's practice. But if it's something that commonly comes up as a question for individual patients, then it will have relevance for that population.
Okay, so you're suggesting relevance to perhaps clinicians in terms of a clinical audience. Who else might be factored into the relevance of the study question? Families. Yeah, so it could have potentially more or less relevance to families if it's something rare, but could have a large impact on caregiver burden, for example. It might make it more relevant, depending on who the audience is. Other thoughts about that?
Insurance companies.
Insurance, so payers, it might be incredibly relevant for them, thinking about quality of life and the costs associated with caring for a child with non-ambulatory cerebral palsy. Absolutely. Yes.
I think it comes down to if you can modify a current practice to make it more relevant. So if you can answer a question that cannot be changed related to a procedure, if it does or doesn't improve something, then it's not really going to be relevant.
So say a little bit more about that.
So I can design the best possible horse carriage, but it's not going to do me any good in today's society where everything is an automobile.
Mm-hmm. Okay.
So I may be able to answer the question well, but if it's not practically or in use anymore, then it's not really going to apply.
Mm-hmm. Mm-hmm. Yeah, that's a great point.
Maybe more than in terms of just cost. You could have a negative answer, but the cost is significantly less for a lab than it would be for a person who's still demonstrated relevance to the cost of the family and cost of the insurance companies.
Mm-hmm. Mm-hmm. So he said related to cost, that you could show measurable differences related to cost. And that is, in today's, that's a very relevant outcome for a number of insurance companies and so forth, families in terms of expenses and so forth. Absolutely. All right. So other comments or questions about what we've talked about so far before we switch gears to hear from you? Does this make sense? And I know, are you feeling a little bit more like this is less of a, obviously that this is an important endeavor, and it's the importance of spending this time up front to sort of pave the way for a stronger, more robust study design? Yes, maybe? Yeah. Yes, okay. All right, so what we thought we'd do is for folks to either work individually or break into a group. If there's a couple of you from a similar department or discipline and you'd like to work together, that's wonderful. To identify your clinical area of interest, so thinking about that inverted triangle again. So defining what your clinical area of interest is and what's known in your field, what's the topic that you're interested in, a couple of bullet points about what's known and what a couple of the major gaps are in the literature. And if you can identify any priorities that might be associated with this research question, whether it be for you personally, departmental priorities, or if you recently attended a conference and there are some national priorities about focusing outcomes research in a particular direction, or professional priorities in your discipline, that would be great to highlight. If there aren't, that's fine. And then what we'd like each group to do is to write a testable, relevant, generalizable research question that includes the three components that we mentioned. So the exposure and some kind of primary comparison between groups, a measurable outcome within a defined sample and or subsample. And we'll take maybe, to do a time, just 10 minutes, you think? Maybe 10 minutes to work on this, and then we'll ask a few brave... Oh, All right, so maybe 5 minutes. So maybe what you can do is focus on, tell us your clinical area of interest, maybe one gap in the literature or one gap in practice if you can, and then really focus on the research question. And then we'll come back as a larger group and talk about it. All right? Here it is. Oh no, my water. I was just looking for my water. Thanks.
Maybe we have a common theme. My problem is I know what I'm interested in, I know what I'm excited about, but I don't know when it's isn't that so obvious? Why should you even ask versus yeah, maybe we should all just jot down our interests.
So I was trusting
Only get 3 to 4. You're getting there. So while she's writing, I'll say that my interest throughout my little thing that I'm working on is to figure out how I'm a specialist, how we can get specialists to get here through a model called medical home, meaning that like the family is very central to your decision making. And one of the barriers to doing that is that we don't communicate with each other very well. I see my patients and I come up with a plan. The primary care providers like, the family gets in the middle. And so I'm looking to, my interest is using Epic to help forward medical care using medical home model without specialists having to give a hoot about what medical home is just because the tools are so good. Don't go like,
I'm looking at epilepsy surgery outcomes and morbidity and mortality, which I don't know how generalizable it is because I think most of the literature, has a number of individual centers presenting their outcome data, but I think that it's clearly a fundamental priority because we need to ensure the quality of our services in comparison to national outcomes to make sure that we are doing things properly and the patients are being well served by having surgery. So, my question.
what's already known?
Well, I think that there are a lot of people who, Cleveland Clinic has published their research outcome or their surgical outcomes over the course of X number of years for different types of procedures. Hopkins, I think, published their hysterectomy outcomes. There's limited morbidity data, limited M&M data about complications of surgery for pediatrics. They just published a recent one about shunts. So there's a consortium of epilepsy surgery centers, which I would probably use as a comparison for outcomes here, for shunts to compare to that national
Technique-based information about outcomes, but not necessarily. Okay, I'm sorry. So you were about to say your question.
Well, it was about, so the first group I'm tackling is hysterectomy patients here over the last 3 years, looking at, mortalities, morbidities, shunts, and outcome.
That's the reason having this information, but
Again, to ensure that practice here is up to the national standard of outcome.
So that's interesting. Where you are now. And I guess that's where I'm struggling with mine. I know that I want things to be better, but I don't know it's better from the patient satisfaction standpoint, from, there actually is stuff known in the literature about how
We're running out of time. That would be a start. Do we have any great volunteers? Sounds like there's a lot of great discussion going on. So this is great volunteers. Great. I'm going to type the question.
I like that.
Okay, well, I don't know if I want to give it to you yet because it's pretty bad. Our first question that we were trying to ask was, do children with pulmonary hypertension show decreased RV function from onset of symptoms within first year of diagnosis? But now our new one that we're trying to figure out is, does our RV function parameters better predict the outcomes that we use now? Because we have a set analysis for outcomes. It's based off of a WHO class. Well, that was intense. But we're doing more mathematical tests with echoes and some of our animal studies, which we think are better predictors of pulmonary hypertension severity than our current outcome models. And so I think we're trying to see or test right now whether our predictor outcomes are better than our old models that we've been using for years. Predict current pulmonary hypertension outcomes models. I guess this is a question about outcome modeling more so. We have pediatric pulmonary hypertension patients, which range from 2 weeks to 17 years old. And our population size right now is about 250 patients, just currently through children's. Well, we haven't translated them into clinical studies yet, so we're still kind of working in that animal trial stuff. But we do catheterization in cattle with pulmonary hypertension, and so we're able to test pulse pressure and cardiac output through these catheters, and we think that's a better test. I mean, it's still invasive, but a better test of severity of pH than some of our other echoes and MRIs and et cetera.
So I would say that probably the first, I guess what I would think would be that the first step in looking at a new model of prediction of severity in pulmonary hypertension is to understand what the current predictive capacity is of your current measurements and translate that into kind of your gold standard to have some outcomes for that first model before you can look at a new model that says, do we do better with this technique than we did with the other one? So I think if you don't have the first one, the current one defined, you can't look at another one because you won't have any way to compare it to anything.
Well, and I think, some of these models have been used for, decades now. So I'm sure I could probably, compare that with, previous literature on how that works. But right. So you would want to aggregate that. Right. What the standard is, and then right. Trying to go for.
But you're not predicting pulmonary hypertension, you're predicting outcomes in patients with pulmonary. more accurately predicts functional outcome in patients
Functional.
with pulmonary.
I don't know really how to narrow that group down from the group we have here.
So one of the things that you might have to narrow down when you start getting into this operation is functional outcomes. They have to be very uniform across the pages. They have big problems. This is why. So they have to do measurement. So that's the kind of issue that may make you circle that. Right, so like if an outcome is validated for children greater than 7 or something, then you would need to do outcomes
In children greater than 7 or whatever. That was already done by that time.
So again, that would go to you need to work up. Is that two different things? So maybe we should try one question.
I'll go. I'm holding the mic, so. I'm interested in creative arts therapy for kids who are getting chemo in the infusion center in the oncology clinic. And I published a pilot study showing trends of improvement in pain and nausea using the PEDS-QL quality of life. And now I have a bigger study going looking at quality of life and some other measures. But my whole purpose is to try to get more funding so that she could be full-time the creative arts therapist and to show that it really makes a difference. And I think in this, in the environment where complementary and alternative therapies are so prevalent that and a big deal right now that I could get the funding if I could figure out how to ask it right. And I'm interested, I was just thinking about cortisol levels in salivary cortisol as a measure of stress. So I have to do a literature search about that. Other things I've looked at are quality of life. We think their posture is better. They stand up straighter. So we have a kyphosis measurement. We could do that. That's what we're trying right now. Or the faces, the emotional response to pain. Nausea is really hard to test.
Okay, so let's start with the patient group.
Okay.
And the intervention and the comparison group.
So
try to just walk it through as a first draft, okay?
The patient group is children with cancer in the infusion center getting chemo.
All kinds of cancer?
Yeah, anyone who gets chemotherapy.
It's a title box, and it's all
0, they're babies. Well, actually, there are babies to like 30-year-olds. She does, she can. But you can't measure very much with them. So we've been doing 3-year-olds, I think. 2-year-olds is the PEDS-QL.
So
2 to 18 is what you can measure in the PEDS-QL.
Okay, so that's a good start. I would wage quite a bit that you're going to have to be much more specific about what types of cancers, where they are in their therapy, all kinds of other things, but that's a good start. Okay, children with cancer getting chemo.
The intervention is a 1-hour session of creative arts therapy. During the while they're getting chemo.
It's a 1-hour
creative.
And could you just mention the outcomes again that you're interested in?
I think change in cortisol levels before and after.
before and after the therapy session.
Yeah.
The art, the creative thing.
For a difference between before, after minus before, what the change is. Do you have to say before and after if you're saying change, is my question, right?
No, no.
Okay.
Well, eventually, you're going to have to be very specific about
But if you
when.
tie in the question, change implies you're measuring, or just say pre and post. You could say
Yeah.
pre-post.
Because I think it also depends on when do you expect the cortisol levels to change, right? So like,
So if the child gets an intervention and cortisol levels drop X number of hours after the stress is reduced, then you should measure cortisol levels X number of hours after you give the intervention. So I think you have to characterize what is the marker that you're looking for and when would it be best to measure it. Obviously it's going to be after, but I think the question is when after. Is it like 1 hour after or like the next day or whatever? Right, exactly. Yeah.
There's a tremendous amount of literature on this because cortisol is tricky. It's very, very tricky. It's easy, relatively easy to measure, but it's very difficult to interpret because of the diurnal patterns of it, all these things that we're talking about in terms of when you expect the change and. So, need for antiemetics. Another outcome.
She said need for antiemetics. Yeah, that's a good idea. It's tricky because they all get antiemetics anyway. And yeah, I mean, we don't have to go into all what's hard about it, but.
I'm also wondering if you'd have to do any kind of multiple baselines, because does the stress start showing up the day before because they know they're coming for chemo?
So I think you can see just from this, our little discussion, how much deeper, how many layers you have to go before you've got a really well articulated question, because you've got some doubts about the outcomes, there's some questions about how narrow to make the patient group, what kind of treatment, and you probably are going to want to have, a fairly homogeneous group if you really want to do a pre-post, because otherwise you're going to have a lot of different things to account for.
That's the problem, though. You can't get the numbers in our institution unless you have a wider group.
and limiting your to a small population decreases your,
Limiting it to a small population decreases your generalizability, right? So if you only have one particular type of cancer with one particular type of chemotherapy in this one place, then how are you going to show that art therapy in general helps children with stress for medical procedures? So I think it has to be like a balance between narrowing it too far so that you're not generalizable, and then making it too heterogeneous when you won't get any positive results.
That is the constant balance we are in, absolutely. And we talked about that last week. We are, balancing that internal and external validity, the robustness versus who it applies to. Yeah, but we should end because it's 1. But we can stay for a minute or two if folks have other questions. Thank you for those who volunteered. That was great.